Okay, I want you to start this deep dive by picturing a blood clot. And I know that's maybe not the most pleasant image to start your day with, but stay with me. Because when you picture a clot, you're probably thinking of this, big red jelly-like thing.
It's like a scab you'd get on your knee.
Exactly.
And that's actually, well, it's pretty accurate if we're talking about a clot in your veins. We call that a red thrombus.
Red thrombus.
It's red because the blood in your veins is moving slowly. It's kind of lazy. So when a clot forms, it just traps everything. Red blood cells, fibrin, the whole neighborhood.
But, and this was the thing that really jumped out at me from our sources, that picture just completely changes when we look at the arteries.
Oh, completely.
It's the high-speed highways of your body, right? The blood is just pumping through there.
Exactly. The velocity is so high, the shear force is so great, you just don't get those big red blobs. The current, it basically washes all the red blood cells away before they can get stuck.
So what do you get instead?
You get what we call white thrombi.
White thrombi. Because they're made of what?
Platelets, almost entirely platelets. They're these tiny, incredibly tough little cell fragments, and they're the only thing sticky enough and strong enough to hold on against that arterial current.
Wow.
A red blood cell tries to stick, it gets blown away. A platelet anchors down.
And that distinction, red versus white, it's everything. It dictates the entire treatment strategy.
It's the whole game. A venous clot like a DVT, you need anticoagulants to break down that fibrin mesh. But an arterial clot, the kind causing heart attacks and strokes, you have to go after the platelets.
So you need antiplatelet therapy.
You do. And that's our mission for this deep dive. We're going to unpack the drugs designed to stop these white clots. And it sounds simple, right? Stop the clot.
But it's not.
It is a biological tightrope walk.
It really is.
Yeah.
Because these drugs, they save lives, no question. But every single one of them, it brings this risk of bleeding. It's a constant trade-off.
That's the question modern cardiology is always asking. How much bleeding risk are we willing to accept to prevent a heart attack?
Thin the blood enough so it gets past a blockage, but not so much that, a paper cut becomes a huge problem.
Or far worse, a brain hemorrhage.
Okay, so before we get into the drugs themselves, we're going to cover aspirin, Plavix, all of them. We need to understand how one of these white clots even forms.
Right. To understand the disease, you have to understand the healthy state first. So, in a perfect world, your blood vessels are actively fighting clots every single second.
Ow.
The cells lining your arteries, the endothelium, they're pumping out nitric oxide and prostacyclin. Think of these as chemical brakes.
So the lining of my arteries is basically non-stick. It's Teflon.
That's a great analogy. Ideally, yes, those chemicals keep the platelets just sliding right by, inactive, smooth.
But then something goes wrong. A vessel wall gets damaged. Maybe it's a cut or a plaque ruptures. What happens to the brakes?
The brakes get cut. The nitric oxide stops flowing right there. And, more importantly, the stuff underneath the wall gets exposed. Suddenly you've got collagen and something called von Willebrand factor out in the open.
And platelets love that stuff.
They have a very specific appetite for it. They have these receptors, think of them like Velcro hooks, that just grab right onto that exposed collagen. That's step one, adhesion.
Okay, so they're stuck there.
Yeah.
But a single layer of platelets isn't enough to block an artery. They need to call for backup.
They do. This is the activation phase. Once they stick, they physically change shape. They get all spiky to increase their surface area. And then they dump their internal contents. They shoot out chemical signals.
Distress flares.
Exactly. Specifically ADP and thromboxane A2.
So one platelet sticks, and it immediately starts screaming, "Hey, everybody, get over here now."
That is precisely what's happening. It's a recruitment drive. And once those reinforcements show up, you need to, hold them all together. You need cement.
The thrombin.
Right. The coagulation cascade kicks in, you generate thrombin, and thrombin converts fibrinogen into these long, stringy fibrin strands.
And that weave the whole pile of platelets together.
It locks it all in place, and boom, you have a solid white thrombus.
Which, on a cut finger, saves your life. But in a coronary artery,
it blocks flow, starves the heart muscle, and causes a heart attack, a myocardial infarction. So if I'm looking at this map like a general planning a campaign, I see a few supply lines I can cut. I can stop the thromboxane radio signal. I can jam the ADP radio signal. Or I could just go right to the end and glue the Velcro shut so it can't stick.
You have just outlined the entire history of antiplatelet therapy. That is exactly what we do. We set up roadblocks at different points on this map to stop that final clot from forming.
So let's start with the first roadblock, the oldest one, the one that's been around for over a century, aspirin.
I really want to understand what's happening under the hood. What does it actually do? We say it thins the blood, but is it just making my blood watery?
No, that's a great question. It's not thinning the fluid itself, like adding water to paint. It's targeting the actual mechanics of clotting.
Okay.
And to understand aspirin, you have to understand the platelet.
The little things that rush in to plug up a cut.
Right. And inside every single one of those platelets, there's an enzyme called cyclooxygenase 1. Let's just call it COX1.
COX1.
Think of COX1 as a little factory. Its only job is to produce a chemical called thromboxane A2.
Thromboxane A2. Sounds like a villain from a sci-fi movie.
In the context of a heart attack, it is the villain. Thromboxane A2 is this incredibly powerful signal that basically screams at other platelets to wake up, get sticky, and clump together.
So thromboxane is the glue.
It's the glue and the rallying cry. It causes aggregation. Now, here's where aspirin comes in, and this is the fascinating part.
Okay.
It enters the bloodstream, finds that COX1 enzyme, and it doesn't just block it for a little while, it acetylates it irreversibly.
Whoa, hang on. Acetylase? That sounds like something I failed in high school chemistry. Can you give me the real-world visual for that?
Yeah. Okay, think of the COX1 enzyme like a keyhole that starts the engine for clotting.
Okay.
Most drugs just put a key in the lock and kind of hold it there. Eventually, the key falls out and the engine can start again. Aspirin is different. Aspirin is like pouring super glue into the keyhole.
Super glue, so that lock is broken.
Or forever.
For the life of that platelet, that enzyme is just, it's dead.
But wait, my body heals, right? If I cut my arm, it heals. Surely the platelet can just make a new lock. And that is the absolute critical piece of this. Platelets aren't full cells. They're just fragments. They have no nucleus. They have no DNA. They can't make new proteins. So once aspirin superglues that COX1 enzyme, that platelet is effectively neutered for the rest of its life.
That's wild. So it becomes a zombie cell.
Exactly.
It's floating around,
yeah.
But its main weapon is just gone.
Gone. And a platelet only lives for about 7 to 10 days, so a single dose of aspirin knocks out its clotting ability for, a whole week. The body has to wait to generate brand new platelets to get that function back.
Okay, that makes so much sense. We're permanently disabling the glue factory in these little zombie cells.
You got it.
So this brings me to my next logical question. If I have a really bad headache, I take 2 Tylenol, not 1. So I really want to prevent a heart attack. Shouldn't I take a bigger dose of aspirin? If 81 milligrams is good, isn't 1,000 milligrams like a fortress?
That would make perfect sense because that's how most drugs work. Dose response, but aspirin has a paradox.
A paradox?
Yeah. When you ram up the dose, say, to that 1 gram level you mentioned, aspirin starts to lose its specificity. It's not just hitting COX1 anymore. It starts attacking a different related enzyme called COX2.
COX2. Okay, and I'm guessing this is an innocent bystander we don't want to hit?
It's more than innocent. It's our ally.
Oh.
COX2 is found in the endothelial cells, the cells that line the inside of your blood vessels. And unlike platelets, these cells use COX2 to make something called prostacyclin.
And what does prostacyclin do?
It's the antithromboxane. It does the exact opposite. It tells blood vessels to relax and open up, that's vasodilation, and it tells platelets not to clump together. It's the body's own natural built-in clot buster.
Wait, hold on. Let me get this straight. Low-dose aspirin kills the bad thromboxane.
Right.
Good. But high-dose aspirin kills the bad thromboxane and the good prostacyclin.
Precisely. You are effectively stepping on the brake and the gas pedal at the exact same time.
You cancel out the benefit.
A lot of it, yeah. And you get more side effects.
That is it's incredibly counterintuitive. So by taking an extra strength aspirin for your heart, you could actually be stripping away your blood vessel's own defense system.
Correct. And remember how we said platelets have no nucleus, the zombie cells?
Right.
Well, the cells lining your blood vessels do have a nucleus. They can make more enzymes. But if you keep bombarding them with high-dose aspirin every single day, you are constantly suppressing that good protective prostacyclin.
So you're left with a system that's confused, less protected, and, as I'm sure we'll get to, probably bleeding more easily.
Exactly. And that's why the data is so clear now. Higher doses are not more effective for preventing events, but they are absolutely more dangerous.
Okay, so the more is better idea is officially debunked. Let's talk about the who. This is the part that I think trips everyone up. The whole primary versus secondary prevention thing.
This is the absolute crux of all the modern guideline changes.
So break it down. Let's start with secondary prevention. Who are those people?
Secondary prevention is the easy one. This is the green light group. These are patients who have already declared themselves. They've had a heart attack, they've had a stroke, they have a stent, or they have confirmed blockages in the arteries in their leg.
So the house is already on fire, or it was on fire very recently?
The fire has happened. We are just trying to prevent it from flaring up again. For these people, the data is just rock solid. Taking aspirin reduces their risk of another event death, heart attack, stroke by about 25% compared to doing nothing.
A 25% reduction is massive.
It's a home run in medicine. So for secondary prevention, unless you have a major reason not to, aspirin is standard of care.
Okay. Now for the murky water. Primary prevention. This is Uncle Bob. Uncle Bob is 60, never had a heart attack, feels fine. Maybe his cholesterol is a bit borderline. He likes his steak, but he's healthy. He takes an aspirin because he wants to stay that way. What do we tell Uncle Bob now?
And this is where the red light, or at the very least a big flashing yellow light, comes on. For a long time, we told Uncle Bob, yeah, go for it. Why not? But we've learned that for people like him, the math just doesn't work out anymore.
Why not? I mean, if it prevents clots, why wouldn't it help him?
It might prevent a clot, but his absolute risk of having a clot in the first place is so much lower than the person who's already had a heart attack. The benefit is smaller. But the risk from the aspirin itself, specifically the risk of bleeding, that stays the same.
So it's a balance scale.
It's a balance scale. And a bunch of recent huge clinical trials have shown that for the average primary prevention person, the risk of causing a major bleed, a GI hemorrhage, or, God forbid, a bleed in the brain, that risk now outweighs the tiny benefit of preventing a heart attack that might never have happened anyway.
That's a really sobering thought. You take a pill to save your heart, and you end up causing a brain bleed.
It's the worst case scenario, but yes. And that's why the guidelines now say do not routinely prescribe aspirin for primary prevention, especially in people over 60 or 70.
Is there any exception at all? Is there any version of Uncle Bob who should be on it?
There is a very narrow slice of the population. We're looking for patients with a really high baseline cardiovascular risk.
And what does that mean in real numbers?
Well, the technical definition is a risk of at least 10% over the next 10 years.
Okay, hang on. 10% over 10 years. To me, that sounds pretty low. If you told me there was a 10% chance of rain, I might not even bring an umbrella. Why is that high risk?
That is a great perspective check. Because in epidemiology, a 10% risk of a catastrophic event is actually quite high.
Sure.
Imagine a room with 10 people just like you. If we know that one of them is statistically guaranteed to have a heart attack or stroke in the next decade, that's a serious public health concern.
Put that way, it sounds a lot scarier, 1 in 10.
Exactly. So if Uncle Bob falls into that 1 in 10 category, maybe he smokes, has diabetes, high blood pressure, and he has a low risk of bleeding, then and only then might we have a conversation about it.
So it's a tightrope. You have to be sick enough to need it, but healthy enough not to bleed from it.
That is the perfect summary.
So assuming someone is on that tightrope and they're taking it, we know the huge dose is bad. What's the magic number?
The sweet spot is 75 to 100 milligrams daily. In the U.S., that's almost always the 81 milligram baby aspirin.
And what about, okay, our emergency scenario? We're at dinner. Uncle Bob clutches his chest. He's sweating. We think it's the big one. What do we do then?
In that acute moment, the rules change completely.
Right.
You need to shut down that platelet factory now. You don't have time for a gentle 81 milligrams to slowly absorb. You give at least 160 milligrams, so 2 to 4 baby aspirins, and crucially, you tell him to chew it.
Chew it? Why chew it?
Chewing breaks it down and allows for much faster absorption through the lining of the mouth. You need that super glue on the COX-1 enzyme immediately.
Chew for emergencies, swallow for maintenance. Got it. I want to circle back to the bleeding, though. We sort of mentioned stomach issues, but it feels like everyone I know who takes aspirin complains about it.
It is by far the most common side effect. Dyspepsia, indigestion, gastritis.
But wait a second. I can hear people listening right now shouting, but I buy the enteric-coated stuff, the safety coating.
Yeah, the marketing on that has been incredibly effective.
Is it not true?
Unfortunately, no. Not really.
What?
The idea is the coating stops the pill from dissolving in the stomach so it doesn't cause direct irritation. And sure, that helps a little with direct contact, but remember how aspirin actually works.
It gets into the bloodstream. It's systemic.
Right. The problem isn't just the pill physically sitting in your stomach. The problem is that the chemicals aspirin suppresses, the prostaglandins, they're responsible for maintaining the protective mucus lining of your stomach.
Oh, So you're not burning the stomach lining from the inside. You're turning off the stomach's own force field.
That's a perfect way to put it. You are systemically lowering the stomach's defenses against its own acid. So the risk of ulcers and bleeding is still there, regardless of the coating.
That feels like a huge myth bust. The safety coating is a major selling point that just doesn't really hold up.
It's misleading. If you're truly worried about the stomach, you should be talking to your doctor about maybe testing for H. pylori bacteria or using a PDE to lower acid levels, not relying on a coating.
And what about this multiplier effect you mentioned? What happens when you mix aspirin with other drugs?
This is where things can get really dangerous. On aspirin alone, your risk of a major bleed is somewhere around 1 to 3% per year.
Okay.
But if you combine it with another antiplatelet, like Plavix, or a blood thinner, like warfarin,
Which a lot of heart patients are on.
many are, that risk can double or even triple. It's a compounding effect.
So if you're on that kind of dual therapy, you have to be really careful.
And you have to keep that aspirin dose low, always 81 milligrams, never 325 if you're on another thinner.
Before we move on, what about allergies? Is aspirin allergy a real thing, or is it just an upset stomach?
Oh, it's very real. And it typically looks like an asthma attack, bronchospasm, your airways just clamp down.
Who gets that? Is it random?
There's a classic triad of risk factors we look for. If you have asthma, nasal polyps, those are little growths inside the nose, and chronic sinus problems, your risk for that kind of reaction is much, much higher.
The asthma polyps connection, that's so specific.
It is. But if that's you need to be incredibly careful with aspirin.
Okay, let's get to the final mystery, which sounds like something out of a detective novel. Aspirin resistance.
Yes, a very controversial topic in cardiology.
The name itself implies that for some people, it just doesn't work.
Yeah.
Like they're immune.
That's the fear. But we have to be really precise with our definitions here. There are two different ways people use that term. The first is clinical resistance.
Name?
Meaning you took your aspirin every day and you had a heart attack anyway.
Okay, but that feels... I mean, if I wear a seatbelt and still get whiplash in a car crash, the seatbelt didn't fail, right?
That's a perfect analogy. Aspirin isn't a force field. It reduces risk by 25%. It doesn't eliminate it. So calling that resistance is confusing. It's just the disease was stronger than the therapy in that case.
So what's the other kind? The more real kind?
That would be biochemical resistance. And this is where we can actually test it. We take your blood, put it in a lab exposed to aspirin, and your platelets. They still clump together. The superglue just didn't work.
The seatbelt was made of paper.
Exactly.
Why does that happen? Is it genetics?
It can be, but more often it's something way simpler. Poor compliance, people just forget to take it. Or issues with absorption. But there's one major cause that everyone who takes aspirin needs to know about, and it involves another incredibly common drug.
Which is?
Ibuprofen.
Ibuprofen, Advil, Motrin.
The very same.
How on earth does ibuprofen mess up aspirin?
They fight for the same parking spot. Remember that KOX1 keyhole?
The one we want to superglue shut.
Right. Well, if you take ibuprofen, it gets to that keyhole first, and it sits there, blocks the aspirin from getting in to do its permanent superglue job. But ibuprofen's effect isn't permanent. It eventually washes away.
The ibuprofen acts like a temporary shield for the enzyme, protecting it from the aspirin, and then it just leaves.
Exactly. And by the time the ibuprofen is gone, the aspirin has already been cleared from your system. So you're left with fully active platelets, zero protection, and a completely false sense of security.
That is actually terrifying. You're trying to save your heart, you get a headache, you pop an Advil, and you've just neutralized your life-saving medication for the day.
It's a very real and very common interaction. The advice is if you have to take both, take the aspirin at least 30 minutes before the ibuprofen. But ideally, if you're on daily aspirin for your heart, you should probably be using Tylenol acetaminophen for pain. It doesn't interfere.
That's a write this down moment for sure.
Huh?
So with all this complexity, resistance, interactions, should we be getting tested? Can I get a blood test to see if my aspirin is working?
You would think so. It seems logical, but the clinical consensus is no.
Why not? If resistance is real, why not check for it?
Because the tests are a mess. They aren't standardized, so different labs will give you different results. And even more importantly, we have zero evidence that fixing the resistance actually helps patients.
What do you mean?
Let's say we test you. We find you're aspirin resistant, and we decide to double your dose. We don't actually have any data that proves that prevents more heart attacks. We just know it makes you bleed more.
So for now, testing is just a research tool.
Okay, so aspirin covers the thromboxane pathway. But going back to our battle map, the platelets have a detour.
They do, a very important one.
We block the thromboxane radio signal with aspirin. but they can still use the ADP radio signal to call for backup.
And that brings us to the second major class of drugs in our stack, the P2Y12 inhibitors.
ADP blockers.
So P2Y12 is a specific receptor on the surface of your platelets. Think of it as a keyhole. When a chemical called ADP fits into that keyhole, the platelet wakes up. It literally sprouts these little arms and gets incredibly sticky.
So if P2Y12 is the activation button, these drugs are basically a piece of duct tape you stick over it.
That's a great analogy. You can push the button all you want, but the signal doesn't get through. The platelet just stays dormant.
And the most famous class here are the phenylpiridines, drugs like Clopidogrel and Prasugrel.
Right. But there's a huge twist with these two. They're what we call prodrugs.
This always seems so inefficient to me. It means the pill you swallow is actually useless at first, right?
It's inactive, yeah. A dud. It has to pass through the liver, and specific enzymes in your liver, the cytochrome P450 system, have to metabolize it to turn it on.
So why do that? Why not just make the active drug in the first place?
It's usually for absorption or stability. The active form might get destroyed by stomach acid, so you have to send in this sort of Trojan horse that your liver then unlocks.
Got it. Okay, let's talk about the big one, Clopidogrel. You probably know it as Plavix. It's everywhere in these studies.
It's the standard for a reason. Compared to just aspirin, Clopidogrel reduced the risk of cardiovascular death, heart attack, or stroke by about 8.7%. It just works better than aspirin alone.
And they seem to be even better together. This dual therapy of Clopidogrel plus aspirin is the standard of care for anyone getting a stent.
Absolutely. For a bare metal stent, you're on the combo for at least 4 weeks. For a drug-eluting stent, which takes longer to heal over, you're on it for a whole year.
And that combination makes a real difference.
A huge difference. For certain types of heart attacks, it reduces the risk of bad outcomes by 20% compared to just aspirin. That 20% is a lot of people going home to the family.
That's massive. And this is where the wonder drug story gets complicated. There's a genetic glitch in the source material that just blew my mind. We said the liver has to turn this drug on, right?
Yes, using an enzyme called CYP2C19.
Okay, so what if your liver is bad at its job? What if your body doesn't make that enzyme correctly?
That is the crucial flaw. We call it phenylpiridine resistance. Up to 25% of white patients have a loss of function allele for this enzyme.
Yeah.
Their liver is just sluggish.
25% is already a huge number, but then I saw the breakdown for other groups. It's staggering.
It is. About 30% of African-American patients and a massive 50% of Asian patients carry this allele.
Wait, hold on. Let that sink in. For half of all people of Asian descent and a third of African Americans, they could be taking this pill every day, thinking they're protected, and their body literally can't turn the drug on.
Effectively, yes. They're getting significantly less protection. The active drug levels in their blood are low, and they're at a higher risk of clotting. It's a huge issue. You might be taking a pill that's doing almost nothing for you.
That just feels like a scandal hiding in plain sight. If we know this, why isn't genetic testing standard before prescribing it?
Well, it's cost, it's complexity, it's workflow. In an emergency, you don't have time to wait for a genetic test.
Yeah.
But this exact problem is why the next drug was developed.
Enter Prasugrel.
Right. Prasugrel was designed to solve that problem. It's about 10 times more potent than Clopidogrel. It kicks in faster, and critically, it bypasses that genetic resistance issue.
So it works for everyone?
Much more consistently, yes. And the trial data showed it was better than Clopidogrel at preventing heart attacks and, maybe more importantly, at preventing clots from forming inside the stent itself, which is a catastrophic event.
Okay, so why isn't everyone on Prasugrel then? Why even keep Clopidogrel around?
Remember the seesaw.
The risk versus benefit.
Exactly. Prasugrel is a more powerful clot stopper, which means it's also a more powerful bleeding starter. The rates of fatal bleeding were significantly higher, 0.4% versus 0.1% for Clopidogrel.
That sounds small, but 0.4 is 4 times 0.1.
Precisely. Which is why the rules are so strict. If you've ever had a stroke or a mini-stroke, a TIA, you absolutely cannot take Prasugrel.
Because of the risk of bleeding in the brain.
The risk is too high. It's also avoided in people over 75 or who weigh less than 60 kilos. They're just too fragile for a drug this strong.
It's a heavier hammer. Great for the nail, but really bad for your thumb. Okay, let's move on to the one that changes the rules a bit. Ticagrelor.
Ticagrelor is different. First, it's not a prodrug, so it works immediately. And second, its binding is reversible.
Which seems like a huge safety advantage. The phenylpiridines are irreversible, right? Once they're on for the life of the platelet.
For about 7 to 10 days, yes. With Ticagrelor, if you stop the pill, platelet function comes back much faster. It's a huge deal if you need emergency surgery.
But there's a weird side effect listed here. Dyspnea.
Shortness of breath, yeah. About 15% of patients get it. It's usually mild, but it's pretty alarming to feel like you can't catch your breath when you're on a heart medication.
And there's a potential safety net being developed for it, something called Prasugrel.
Yes, an antibody fragment that's designed to be a direct reversal agent, an off switch in an emergency. It could be a real game changer.
Okay, last one in this group. The sprinter, Cangrelor.
The niche player. It's AV only, and its half-life is just 3 to 5 minutes.
3 minutes. You blink and you miss it.
That's the whole point. It's used only during a procedure like stenting. You turn the drip on, the platelets are blocked. You turn it off, and an hour later, they're working again.
But there's a trap here, isn't there? The notes mention a major interaction.
There is. You cannot give the oral drugs, like Clopidogrel or Prasugrel, while the Cangrelor is running.
Why not? You'd think you'd want to get them on board as soon as possible.
You would, but Cangrelor binds to the receptor so tightly that it physically blocks the oral drugs from getting in. They just bounce off and get cleared from the body.
So you think you've protected the patient, but really the Cangrelor blocked the dose, and when you turn the drip off,
the patient has zero protection. You have to wait until the Cangrelor infusion is stopped before you give the oral loading dose. It's a critical timing game.
Wow. Okay, so we've taped over the activation button. Let's shift gears. Segment 2 brings us to Dipyridamole, which works on a totally different system.
We're moving away from the platelet surface now. Dipyridamole works inside the cell. It inhibits an enzyme called phosphodiesterase, which boosts a molecule called cyclic AMP, or CAMP.
I always get lost in the alphabet soup here. What does CAMP do?
Think of CAMP as the relax signal. It tells the platelet to chill out by lowering the amount of calcium inside it. Platelets need calcium to get activated. No calcium, no clot.
So instead of blocking the on switch, we're just flooding the room with a calm down signal.
A very good way to put it. This drug usually comes in a combo pill called Aggregation with a little bit of aspirin, and it's used mainly for preventing a second stroke.
But there was some controversy here, the Aggregation debate.
There was a massive trial with over 20,000 patients compared it to Clopidogrel, and it failed to prove it was better. It came very close, but couldn't quite get there statistically. Plus, it has a habit of causing headaches because it dilates blood vessels.
And that vasodilation causes another problem, right? This coronary steal phenomenon.
Right, and that's why we don't use it for heart disease. If you have a clogged artery in your heart, that vessel is already wide open trying to get blood through.
It's maxed out.
Exactly. So if you give a drug that dilates all the other healthy vessels, blood takes the path of least resistance. It flows away from the clogged artery.
It steals the blood from the part of the heart that needs it most.
Precisely.
Yeah.
So great for the brain, but a no-go for the heart.
Okay, let's ramp up the intensity. We've blocked the button, we've sent the Chillette signal, now we get to the heavy artillery, these superglue blockers.
IIIa antagonists. This is the absolute final common pathway of clotting.
I love this analogy. If platelets are the bricks, a molecule called fibrinogen is the mortar. The IIIa receptors are the hands that the platelets use to grab that mortar and stick to each other.
And there are around 80,000 of these hands on every single platelet. It is by far the most abundant receptor. If you block this, you are effectively handcuffing the platelet. It can't stick to anything.
So who are the players? I see Abciximab, Eptifibatide.
Abciximab was the first, a big antibody fragment, but it's not really on the market anymore. The ones we use now are Eptifibatide and Tirofiban. They're smaller synthetic molecules.
Okay, I have to stop on Eptifibatide. The source says it mimics a protein found in snake venom.
It does. It's modeled on a compound from the venom of the southeastern pygmy rattlesnake.
That's insane.
Nature is the original biohacker. The snake uses it to stop its prey's blood from clotting so the venom spreads faster. We just copied the design and turned it into a medicine.
We stole a weapon from a snake and turned it into a shield. That's incredible. But because we're being so aggressive here, handcuffing 80,000 hands, there's a big risk.
Thrombocytopenia. A dangerous drop in your platelet count.
Why does that happen?
It's an immune reaction. Sometimes when the drug binds to the receptor, it changes its shape just enough that your immune system doesn't recognize it anymore. It sees your own platelet as a foreign invader and attacks it.
So your own body eats your platelets?
In a sense, yes. Again, you shift the seesaw, you stop the clot, but you risk catastrophic bleeding because you have no platelets left.
All right, one last category. The long hauler. Vorapaxar.
Vorapaxar is totally unique. It doesn't block ADP. It doesn't block the hands. It blocks thrombin, which is the most potent clotting activator we have.
The big boss.
The big boss. But the truly scary thing about Vorapaxar isn't its target. It's the half-life.
It says here, 200 hours.
200 hours.
That's more than a week.
Once this drug is in your system, it's there for weeks. There is no off switch. There is no reversal agent. You are committed.
Why would anyone take that risk?
Because for certain high-risk patients, people who've already had a heart attack, it reduced the risk of another event or death by 20%.
That's a huge benefit.
The but is that it doubled the risk of intracranial hemorrhage, bleeding inside the skull.
Oh, and if that starts?
It's incredibly difficult to stop because the drug is still there, working. That's why the contraindication is absolute. If you have any history of stroke or TIA, you cannot touch this drug. It's just too dangerous.
So, as we wrap up, it feels like we've seen this evolution from using a sledgehammer to using a scalpel.
Absolutely. We started by just broadly trying to thin the blood. Now we're targeting these incredibly specific receptors, ADP, phosphodiesterase, GPI-IBO, thrombin.
And the main takeaway for me is how much this depends on the individual patient.
That's the whole move toward personalized medicine. The best drug isn't just the strongest one. It's the one that fits your genetics. That CYP2C19 enzyme, your age, your weight, your medical history.
It is not one size fits all.
Not even close. It's about tailoring the biohack to the specific human being in front of you.
Thanks for diving deep with us today on controlling the clot. Stay curious.